morning. It gives me great pleasure today to introduce our visiting professor for the month of June. It's Dr. Vince Rowe. Dr. Rowe is a native Angelino. We brought him up here and he brought some good weather with him yesterday and the day before. So the rain, Vince was a little chilly last night, but we got him warmed up. Dr. Rowe went to Berkeley for undergrad. He went to USC for medical school and then went to Kaiser for his residency. He spent a couple of years in Tennessee during his fellowship, which he talks, adoringly about the state of Tennessee. And then he came back to LA. He was at the University of Southern California for 23 years and was a leader in everything he did. He has over 130 publications. He has 40 book chapters. He's been the past president of the Western Vascular Society. He's the president-elect for the Society of Clinical Vascular Surgery. We recently had Alec Farber out here who talked about the BEST CLI trial. Dr. Rowe and his team at USC were the highest enrollers in the BEST CLI trial, and he has found a lot of nuances through that trial. I'll be talking about it today. But in 2022, he was named the Wiley F. Barker Endowed Chair and Chief of Vascular Surgery at UCLA. And we're interested in hearing what you have to say today, Vince, and it's been a real pleasure having you here the last couple of days. So thank you very much.
Thank you very much. And thanks for coming out so early. 6:30 is tough, even for surgeons. So I really appreciate it. And thank you, Dr. Wood. You go to a lot of places. Chairs are busy, chairs are traveling, chairs have obligations, and oftentimes they can't be there. But I really appreciate you being here. And I just appreciate the support. So thank you. Let me go ahead and get started here. And I have no financial disclosures. But one thing I wanted to say before I get started into the talk is, this picture is pretty prominent across the University of Washington Department of Surgery, across the internet. And I think there's a lot of things for the vascular division. Those are the people that I interacted with most throughout the years. But I think there's a lot that you can see there, not just the faces, but the expressions on the faces, the camaraderie, the team spirit. I think it's all there. The look in their eye, like they're ready to move forward and conquer the next case that came in, the next patient, the next difficult situation that they're involved in. They're ready to work together and have each other's back. And I think this epitomizes the team that's here at the University of Washington that was built by great leaders in the past. And then most recently, Dr. Starnes, and the next leader is coming. But right now, Dr. Nitin Singh, which I feel is capable of doing that job, is right now leading them during this time of transition. And so I just want to say congratulations to the vascular division here and everybody that takes part in it and contributes to this great division to be able to be leaders in vascular surgery that they've been over the last probably 4 decades. So congratulations to all of you. So I wanted to do this talk is the handwriting on the wall. And I'm not a biblical scholar, but some of the things that we say in life actually come from biblical origin. And I'm not here to convert you or to dissuade you or anything. It's not a religious talk, but you have to think back that, this was one of those sayings, made it by the skin of my teeth. That came from Job, split the baby. You hear people use that term in law. That came from interactions with Solomon. And is the handwriting on the wall. Well, where that came from was this King Belshazzar. And this is representative of a Rembrandt painting. He reenacted this as to what he saw. And Belshazzar had this great kingdom and was just totally dominant and started to use all of his power in a negative way and became somewhat abusive with all of his power. And so at one of the big feasts, they're sitting there and just enjoying all this lavish food and drink and everything is happening for Belshazzar. And then the story says that this hand, just the hand, comes up and starts writing on the wall. And everybody at the feast is kind of aghast and like, oh my gosh, what's going on here? As this hand writes these things out, he calls different people, as different scholars, to come and interpret what's been written on the wall. First, they're scared about that the hand was just writing something. And then what was written, what did it mean? And so he had to finally call Daniel, and Daniel came and told him what it meant. And this is what Daniel wrote about it. And it says, I'll just kind of go, this the saying right here, I'll go in the red. Thou art weighed in the balances and found wanting. And then it goes on to say, your kingdom is divided. It's going to be divided and given to the Medes and the Persians. And he was upset because he was going to lose his kingdom. But for us now, in terms of vascular surgery, we have a kingdom. And I kind of interpreted it as, is the handwriting on the wall for us when it comes to PAD? Are we going to now lose our kingdom and it will be given to interventional radiology and cardiology because we're not doing what we really should be doing when it comes to peripheral arterial disease? So I just want to take you through somewhat of a journey. Yes. Thanks. Take you somewhat through a journey because we've had some landmark events. Let me see that it's not moving though. There we go. We've had some landmark events in vascular. A lot of diseases that everyone deals with has recurrent trials, and sometimes they're landmark trials. And for us in peripheral vascular disease, we didn't have very many. We didn't have a big landmark trial that changed us until recently. And in December, we had the BEST trial that talked about how you deal with patients with critical limb ischemia, and it randomized patients between having a bypass or having endovascular techniques, which we all do now, much more modern therapy. It came out that bypass was slightly better in terms of patients when there was an adequate vein, and when there wasn't a good vein, they were pretty much equal. And at the same time, over in the UK, the basal trial came out, much less patients, but they said that actually bypass is better with their outcome measures, which was amputation-free survival. And they said that bypass, actually endovascular was better. And so we had these two trials and big landmark time for us, a lot of critique, a lot of discussion. And so I said, well, why don't we just kind of take a look and see where the landscape is, and see where we are with peripheral vascular disease and kind of see where we are. Where are we in the balance? And so I wanted to just kind of ask three questions to myself and then also to you to answer to see where are we with the disease, where are we with the disparity, and where are we with the treatments? And so that's what we'll go through today. So what about the disease? Well, the disease is not very good. It's pretty bad. And we're still trying to figure out how many patients have peripheral vascular disease. We know it as the patients that present with trouble walking or ulcers on their feet and so forth, but how is it, we're not actually have a very good representation. Why? Because there's still a lot of patients that are asymptomatic. We oftentimes don't include the patients that have prior been treated, and we kind of exclude those because they've already had amputations and so forth. So we missed a real number. And the estimates, I think, are behind. So we really need to go back and do another analysis to see how many patients are affected. We do know that as they age, increased likelihood of having the disease, increased prevalence as well. And we know who's at high risk. By far, African Americans are at the highest risk, followed by Native Americans. And that's definitely the same whether you're a woman or a male. And so those are the things that we definitely know about the disease. And the impact, we know the risk factors. And some of the risk factors are pretty severe in terms of what seems to cause the most. For us, definitely smoking is way up there. And smoking has continued to decrease in the United States, but it's still a big factor. And even though it's down under 15% reported for the United States 5 years ago, it's still a big part of the patients that were in the trial. 35% of the patients still smoked actively than they were in the BEST trial. So you can understand the impact of smoking that had on these patients. Diabetes is a big tsunami of diabetes coming, it says. And you can see it increases in everybody, all races and genders. It's going to be a huge increase that we're going to see with diabetes. And so you wonder what's going to really happen in the future. In fact, they estimate that especially in adolescents, we're going to see a lot of patients increase with diabetes. And those that are pre-diabetic, it's going to be hard for them to offset it. We're talking about different therapies, the role of morbid obesity surgery, the role of Ozempic, and all these other things. So hopefully they can offset it. But otherwise, we're just going to have a huge, huge tsunami of diabetes here in the United States. How are we doing globally? Well, sometimes you have to just step back and look at what's happening in the world with this same disease. And globally, the deaths are increasing from peripheral vascular disease. And so although we're struggling here, the struggle is actually just as bad across the world. And in fact, they estimate that it's going to continue to increase, and the morbidity and days lost are really increasing amongst both genders. So it's something that we're going to really have to pay attention to, because a lot of the countries don't have the resources that we have to be able to fight it. And in fact, they said in this article in JVS, I think Dr. Goodney was one of the authors, he said this pattern represents a major public health challenge that warrants a coordinated and targeted response from governmental and private institutions alike. And they're really worried about what's happening with this. If you look at some of the countries that they talk about who has a high income, middle income, and low middle and so forth, this is just how they categorize it. But if you look at how the diseases patterns are in these countries, it's increasing, especially in those that are considered lower income countries. And they're seeing a lot of growth, especially in younger patients, and actually all through, but definitely in the younger patients, we're having a big increase in PAD. And so we really have to try to concentrate on this effort. We can't just focus on us and knowing that everybody else is dying of PAD across the world. And these are some of the other global increases that they talked about. So this, I was pretty surprised. I didn't realize there was so much PAD in this region of India. This is us here, the Americas, right over here. The higher income side, the lower income side being more Central America. But the disease is just spread all across the world, especially in other areas. So we have to be aware of it. And if you look at some of these heat maps, you can see how it's transitioning as we move more from the dark blue to the red, how the disease is migrating over the last 30 years. And it's interesting because they have some of the same issues in terms of what's affecting them. The high glucose is an issue. So diabetes is running rampant. And kidney dysfunction, smoking is a big issue in a lot of the countries. This is a global impact, not just what we see here in the United States. And if we look at diabetes type 2, this is from the global disease burden. They say it's increasing definitely in all these groups, incidence, prevalence, and death rates. So PAD is increasing, diabetes is increasing globally, and we have to kind of be aware of it. What other contributors? They talked about overweight. Well, that's a big issue. This is how we're eating across the world. We're number one in the US, unfortunately, but other countries are increasing over the last 45 years. And I thought this was somewhat interesting. They gave some of the maps in terms of how the BMIs have changed for people across the world, and it pretty much tried to categorize every country. If you look around, you can see all the different regions that they had: Central America, South Asia, Polynesia, and Central and Southern Africa. But you can see for men over there in 1990 and then over here in 2022, the changes that took place. And it's pretty similar when you see the look for women. And then what was somewhat depressing was when you look at children under 18. For men, look at the significant increase in a lot of these regions. And here for women, for young girls. And I said, wow, let me look in this region. I don't know what's going on there, but there's a significant increase that's been happening. And I was curious, so I zoomed in and said, what's going on there? And I don't know if it correlates, but I said, wow, well, McDonald's has now moved out there. They moved to that region, and that's one of the most remote McDonald's. And, you just have to wonder, is that a big deal? And this was the meal that they had that they were advertising on Samoa. It was like, look at, you can get, all these burgers, all these fries, chicken McNuggets, all for about $50 US. So you could feed a whole meal, a family, and be able to take care of everybody with just this meal. But what's it doing to their health? And as you saw, their increase in obesity is really being pretty dramatic. not to criticize McDonald's, I like their fries and I have a burger every now and then, especially when I travel. But this was uh, um, a dissertation that was put together by these researchers. They looked to see what McDonald's strategy was when they became so prevalent in India. And they basically said, you know, their motives were so stealth on how they were able to convince Indian people to eat McDonald's just by having different meals. In fact, some of the workers would dress differently. So you had a worker, say, dressed in blue that was going to be dealing with the meat products. And because of the high vegetarianism there in India, you had a worker dressed in red if they were dealing with no meat products. So if you were vegetarian, you could still order from the guy in red. If you're not vegetarian, you'd order from the guy in blue. And how they changed the menu to be able to accommodate everybody to get them to eat there. And it was successful. But how successful is it for the people? If we look at the diseases, everybody talks about them increasing. And unfortunately for us in vascular surgery, we're going to be the specialty that's going to be in big demand. And we'll have to figure out how to handle that in the near future. But we're not very well distributed. In fact, now there's a number of counties that are not very well distributed with vascular surgeons. As you guys know, here at Washington, you're transferring people in from Idaho, Alaska, wherever, where there's no vascular surgeons. And because of the pandemic, we're seeing a decrease in people that want to continue working, some that want to leave the workforce early. And so we're seeing a little bit of an issue in terms of our workforce and having enough people to take care of all these sick patients that are going to be occurring. And these are the numbers of vascular surgeons per capita. We're doing pretty well, but we still need more. But in these other countries, you can see it's not very good. And so if you look at things, if we say, well, where are we with how we're handling PAD? I have to say we're still wanting. So I think we still have a ways to go. What about disparity? We know there's a disparity. There's a lot of disparities in every disease. In fact, the Institute of Medicine said back in 2002 that they needed to do something because they were very concerned about the disparities that they had in medicine. And in PAD, it's definitely there, but they just took a global approach and they came together and said, with all of these issues, we need to somehow change things, different care. We need to make sure that we identify interventions and programs and different things that we can do to try to address these. So it was pretty much a global issue that they were trying to move forward. And because the Institute of Medicine carries a lot of gravitas in terms of moving forward our care for patients. And, like I said, when we started, this is what we know. I started looking at this when I was at USC, just finishing fellowship. I started to see differences that I thought in outcomes related to my Black patients and Hispanic patients concerned as opposed to my white and Asian patients. And I wrote one of the, I don't think it was a great paper, but we just looked at it and what I saw in front of me when I started working as a young attending. And I saw the African Americans that I was treating were doing worse in terms of primary patency and also in limb salvage. Their limbs, we were losing their limbs a lot faster than anybody else in terms of their ethnicity group. And so I said, well, I think there has to be something to this, but I felt that I couldn't blame compliance. People said, oh, there's a lot issue with compliance. Nobody shows up. Well, no, in a county system, everybody has issues with compliance. Everybody has some type of socioeconomic system. They know they're uninsured, and a lot of people are not an issue in terms of being referred by a particular physician. They're self-referred. Pretty much there's no bias. We try to do the same thing for everybody, regardless of race. I was the physician. I wasn't biasing against Black or Hispanic. I felt like I was treating everybody the same. It was a single institution, and all of these different issues, I felt, well, it can't be anything. I'm treating everybody the same. They're all presenting worse. So I felt it was the patient. That was my conclusion. I said, wow, there's a difference in African Americans in how they handle PAD. Just like there's certain groups that may get Tay-Sachs, there's certain groups that may get sickle cell disease. This group is not doing well with PAD. And that was my solution. And I felt that pretty strongly. I couldn't say it at meetings because people tried to believe it was all the other factors, but I believed that for a while. And then we looking at amputations, although they were coming down, there were still issues in terms of the Blacks having higher amputations. And even as it continued out to the 2020, you could see that it was still happening, that there was still this disparity that was there. And again, even with all this data, I still felt it was the patient. But how, I don't know if I was right, because then came the issue where we switched it to the providers. We said, well, it's the providers. Maybe they're the ones that have the issue. And I was like, no, I'm not, I don't have one. But so I still kind of stuck to it. But studies like this came out. And this is the study where in the New England Journal, where they had these actors read off a script and then to family practitioners. And they said, okay, are you likely to refer this patient for their chest symptoms for a specialist to go see a cardiologist? And when they reviewed it all, basically less people were referred that were underrepresented minorities. And so they said, it's the providers, there's something going on. And it was interesting when you read the article, there's nothing in there that talks about this implicit bias, which has kind of flooded us in the last 15 years, probably the last 10 years. And that's now the buzz term that we use. It's us. We have these biases that we're not even thinking about. And that was pretty much what the article tried to show, and has said that those are the issues that can be leading to some of the disparities they see. And they even talk about that we may not understand the cultures of all the people that we see. There's no number of different cultures, and they show this in a number of different books. And so it said, okay, maybe it is the providers. But I still think there was other questions, because there were other issues that you could talk about. What about the institutions? Could they be the ones? Because they noticed that when you work with a team approach, as opposed to just individuals, perhaps that bias goes away, because now you have a number of different people working on the patient and you get better outcomes. But now they came back and said, well, actually, it's not the institution. It could actually be the surgeon, because if the surgeon has a lot of experience, they're the ones that are driving the benefit for these patients. But so it just kept going around. And lastly, it said, well, now enter the social determinants of health. There's other factors involved, putting it back to the patient. And so they said, it kind of came forward in the cardiology literature. And this is what they saw. Despite all the advances in their care for congestive heart failure, they saw an increase in each year with these patients. And the increase was definitely determined on ethnicity and socioeconomic factors. And so they said there has to be something more to this, because we're advancing the care, but it's still getting worse. So what is going on? And that was what kind of led people to start talking about these other social determinants of health. We actually track those at UCLA, and they have a little thing at discharge, and you can see what is an issue for the patient, whether they fulfill a lot of these different determinants that could be an issue for their care. And it's just interesting to see that we've kind of transitioned now. Here we go. We have a lot of papers that we're talking about. Well, these guys have a higher rate of wound infections. They have a higher rate of amputations, mainly because of these social determinants of health. And so when you put all this together for the disparity, you just wonder which one is contributing to it, or are they all to it? But we have a little bit of a breakthrough, and I think it's going to make people kind of step back and wonder what it is. In fact, I'm on both of these studies. They're both unpublished, but they're going to be presented very soon. This was a study from Ohio State, and they said, okay, let's see, we're going to have a clinic where we have the highest risk patients, and it's going to be a specialty clinic, and then we're just going to have our regular clinic. And we're going to see exactly the difference in these patients and see what the outcomes are, see if it makes a difference. And so in their high-risk clinic, they had more Black patients, Hispanic patients. They definitely had more diabetes. They had more dialysis patients. The patients were younger. They had more patients presenting with advanced disease. But when they went ahead and looked at the outcomes, they were the same. And I remember they called me, they said, I can't believe it, it's the same. I was like, well, actually, that's a good thing, because here it is, you're able to level everything by having this specialty clinic. You've lost the disparity. So perhaps you're finding something that we need to be aware of. And they couldn't find in all their outcomes, just maybe a little bit. One was barely significant. And so what did they do right? Or did they even know what they did right? And again, we talk about that BEST trial. This is the trial, again, 1,800 patients. And this was the demographics of the patients that they had in the trial. So fairly representative, because when you look at the US Census, 12, 13% African Americans. And in the trial, we said they're high risk. So they had 19%. So they did a good job of enrolling people that were probably going to have the disease. And same for the Asian and Hispanic, they were a little bit lower because the number 19% versus 13%, but still, they did pretty good. And so after the main outcome of the whole trial came out, we went and we did a secondary analysis and we looked at it by race. Now, although the trial wasn't randomized for that, we just said, okay, we were in a very confined, a very structured environment. Let's at least see what the outcomes are. And these were the outcomes. Basically, we divided it up into black, white, Hispanic pretty much. And you could see that the black patients basically had more hypertension, more renal failure. A lot of the black and Hispanic patients did not smoke, and they had more diabetes, definitely in the Hispanic group. They presented with more advanced disease. But when we went and looked at all the analysis, no difference. Everybody was pretty much the same. So what is it? In 1,800 patients, we couldn't find a difference. That's one of the largest PAD trials. But we always talked about these disparities as disparities. So what is the answer? I don't know. But it does seem that we're making some progress because these two studies are starting to say that if we somehow work together and take advantage of all the minds that come in to treat these patients, we can get similar outcomes in our high-risk group as we can in the group that's not as high risk. And so there is some type of mix, I guess. I think it all comes together, but I think we're actually getting pretty close to figuring this out. And I think these two studies give encouragement to the fact that you can close a disparity, perhaps by integrating all of this. You're more culturally competent, you've tried to decrease bias, and we're treating everybody the same, and we're in a structured environment, and we're able to decrease it. So I think there is some hope. And so if I look at how we're doing with the disparity of PAD that we talked about, I think we're winning. So I give us a plus because of the advances that we're going to be seeing pretty soon. Last question, how are we doing with the treatments? Well, the treatments have come a long way. We didn't know how to suture vessels until Dr. Carell came along and taught us how to suture vessels. And he was so precise that he would hold the sutures in his finger. He'd hold the needles. He wouldn't use a needle holder. He'd hold them in his fingers and pass it through the tissue so that he can make sure that it didn't cause as much tissue trauma. And you can see, people, when we're teaching medical students, how they try to get, he said, no, I'm going to make sure I pass it through as gentle as possible. And I won him the Nobel Prize to basically teaching us how to triangulate the stitches and sew vessels together. It was basically the start, I believe, of vascular surgery. And then we finally learned how to do bypasses. Dr. Kuhnlin was, he's studying under another gentleman that we know in vascular, Lariche. And he had a patient that presented, he was 54 years old, had toe gangrene. And they were able to see that the patient had, an occluded superficial femoral artery and wanted to try to do something. They were still doing interventions, but he wanted to do a bypass. So he took the vein and sewed it in above and below the area, got better blood flow to the foot, and the guy lived. But he did it all while Dr. Lariche was not around because Dr. Lariche didn't believe in that. So he was kind of a rogue trainee that went and did it, but it worked. And what was different was that he sewed it in the end of the vein to the side of the vessel, as opposed to trying to put it directly and take away all the collateral vessels that formed. He did it on an end to side method. And really, this is still the method that we completely use in our bypasses to date. So 70 years later, we haven't changed. The story has it that he ended up doing a bypass on the guy's other leg, which was successful. And then the guy ended up dying of a stroke a year later. So it's pretty much consistent with what we're seeing now. So, that's how it continued. And then from there, we had a lot of other contributors that were able to help us do bypasses farther and farther and farther down the leg, all the way down below the ankle. And they all made great contributions. What about endo? Well, endo started right down the highway here at Oregon, Dr. Daughter. And he was considered the father of endovascular surgery. And they talked about in this paper how he started doing things. And this was a lesion that he had in patient number 1. I believe she was like 80 years old. She didn't want an amputation. She was active, and this is her foot. She developed gangrene. And I don't know who took the toes off for her. I don't think Dr. Daughter did. He was a radiologist, but he basically went and dilated the area that was narrowed. And you could see the result from originally A all the way to C, how it improved. And her blood flow got better, and she was able to heal. And in his landmark study, he talked about doing 15 lesions like this in 11 patients. And he actually went antegrade, in that he stuck going down this way. He didn't go up and around. He could do that with other things, but for this, he recommended just going straight down from the femoral artery in the groin, straight down to treat the lesions with dilatation. And it changed everything. In fact, surgeons started to send him patients. And if you look at this, this is a prescription from the doctor that sent him over. And he says, okay, you can do the angio, but visualize, but do not try to fix it. Because the surgeon said, I'll do a bypass, so do not try to fix this. And you can kind of see in here, he says, at the adductor level, that's where he knows the blockage is. And so then Dr. Daughter saw the patient, saw that they had actually a stenosis where he said, but also had one in the profunda femoral artery as well. And so he decided to dilate the profunda, because he said not to fix the one in the superficial femoral. So he dilated the profunda successfully. And then to really stick it to the guy, he shows this picture of the patient and him hiking up on Mount Hood, that the guy could walk better after he just treated his profunda femoral vessel. And so he didn't need a bypass. And so some people think this is kind of where the whole conflict of vascular and IR started, but it definitely was credit to both of them, these two great individuals that were able to advance our field to where it is now. And, it's kind of hard to compare who contributed more. It's like trying to compare these two guys, both great athletes, but again, each one great in their own right. And when you look at the two trials that came out, comparing the two modalities that these two people really started, I think it's pretty challenging. But then at the same time, we as the current surgeons have just been very critical of the two trials. And I never could understand why. And we ask questions like, well, is this real world? I can't believe that those aren't the patients that I'm seeing. And, so it can't be what's really in the real world. And I understand why they say that, because it took a lot of patients to be seen to be able to randomize the amount that they had. In fact, in the basal trial, only 10% of the patients seen were randomized. But sometimes that happens. Patients don't enroll in trials for a number of different reasons. And this paper talked about how if you look, they looked to see how many patients were being seen at the sites that were randomizing for the best trial. Well, how many patients did you see that you didn't put in the study? And you can see some of these sites saw, over almost 150, 200 patients, but they only randomized about 10% of them. And so it made everyone question, well, I don't know if this is really true. And so this trial is just not what we're seeing. The other thing they've asked, is it practice changing? And I don't know, I thought it would be, but right now it may not be. I remember I looked back and I said, okay, because I was asked to talk about this at a conference. I said, what was practice changing for me? And you should kind of look back and see what paper just absolutely changed what you did. Well, these were two that did for me, the ACAS trial and the NACIT trial. Those were trials that were on carotid disease, one asymptomatic, the other one symptomatic. Absolutely changed what I did. Didn't even think about it. I was like, okay, this is what I'm doing now. Not even going to think about it, not going to critique. I don't care if it's real world, not. It was practice changing. This was another study. I said, they were talking about whether you give patients protamine to reverse the heparin at the end of a carotid surgery. I didn't. I never gave it. And I said, I don't think I need to. I read this paper. It said if you give them protamine at the end of your carotid surgery, they have better outcomes, less strokes, less hematomas. Boom, changed the next day. I didn't go, well, I don't believe it. All this, I changed it the next day. And this was one more. And this turned out to not be true. But it talked about the fact that as we have these balloons and we line them with different drugs, this one was with paclitaxel, It was a meta-analysis, and they said if you do that in these patients, oftentimes you're going to have increased death rate because they're going to have a cumulative effect of that drug in their system. And I said, okay, well, it doesn't sound like it's too hard for me. I'm done. I'm going to use a different balloon. Now, we challenged that as a specialty, and it turned out it wasn't true. But right away, those were practice changing papers for me in my career. And you should think of the ones that really made you change. What was the impact that made, what papers had impact in what you did with your patients? But for us, we've been using more endovascular therapy, very little bypasses, and I don't know if that's going to change. Because this practice said bypass was better, I don't know if that's going to make a difference, because as a specialty, the ones that are increasing we're contributing to it, vascular and cardiology. So we're increasing. And we've gotten to the point where some people think we're actually overusing our techniques with endovascular. We're over treating patients. And that's been coming out in the news medias, and it's making people concerned how the media is now dictating things in terms of what type of level of justification we have in treating our patients. Is it going to take some other things that change? Is it going to take different guidelines? What happened here with how we used to place IVC filters? I haven't placed one now in probably about 3 years. I was placing one probably 3 times a week, and all of a sudden things changed. I don't know whether it was the guidelines or whether it was some of these fears of lawsuits. Is that what's going to happen for us in PAD? Do we need to have something like that happen where we kind of slow down in what we do? And it's very tempting, though, because with endovascular, we're seeing more and more technology. It's getting better and better and better. So I don't know if it's going to change the practice, because we're somewhat entrenched in what we do, and it's hard to make you change. And unfortunately, a lot of what we do with our balloons and stents reimburses a lot more than what we do with a surgical bypass. And so we work in a fee-for-service environment. So is that going to be an issue for us as well? And so based on all this, the data that came out, but the fact that I don't know if it's going to change people's practice, I kind of said with procedures and treatments, I said it's pretty balanced, because the data was so landmark, but I don't know if it's going to make a change. I'll give it some time to see if it does. It didn't make an immediate change for anybody, but let's see. Let's give it another 2 to 3 years to see. So we have to give them a chance. I think it's pretty balanced. So what about the future? And let's see. Well, this will be in closing. Well, I think we're going to need more data. And I think we have to continue to work as a team, definitely. And I think we have to increase recruitment. Some of you in vascular have seen me talk about this, but I still think we can do it. I still think we can do it, because personally, I'm tired of seeing this. I see this slide all over, pipeline. And, I don't know, I was lucky enough to kind of squirm through it. It was hard for me, but I made it through. And other people are making it through. And that's all I keep hearing. But I think we need to blow this pipeline open with so many people coming in that it's not even an issue. And we just break open those last segments where it narrows down. It's because you have such a big N of people, and we just got to recruit. I talked about this kid, the kid that the video game people, they sent out this whole gaming thing to people. This kid is sitting in his mom's basement in his underwear playing video games. He turns out to be the best guy at this video game. They give him a driving contract. Now he's driving professionally. How would they have found him unless they went out and looked? Then recently I met this guy at UCLA, Dr. Covarrubias, and he's one of the researchers there. And in talking to him, because one of the people that we had applying researched him and said, I want to meet this guy. And so then I found him and I met him, and he's right there on campus performing research. But here's what he said about his story. Read it. He said his background. So, I graduated. I lived in South Los Angeles, first generation college graduate. I was able to and UCLA came out and had this UCLA City Lab, where they went out and they just set up a lab and had people come and get experience of working as a scientist. And he said, because of this defining moment in my life where I decided that I was going to be a scientist, just from that one day, that one visit changed his life. And now he has a successful lab there. He has people coming in, working with him, and he's working with this agency again. Just that one day changed his life. And so why can't we do it? I keep saying, we get these things, we have to do something of getting out there. I don't know if it's a truck, if it's a mobile unit or this or that, but somehow we get out there and we put in that station, a suturing station, laparoscopic station, robotic station, and we take it to the people. And we try to recruit. We try to get as many as we can. We don't know who the next DeBakey is, the next Nissen, the next whomever. They could be out there like that other kid in their mom's basement. But we got to go find them. And we just park this thing all over the place and we go and get all these kids. If they can't get to the medical center, we take it to them and we can find people. We can find people. We can go to every area. There'll be no group that will be excluded. And we'll be able to find people to help recruit. I think we have to be active about it. We can sit back, with our bow ties and talk about p-values, or we can go get some patients. Not get patients, go get some physicians and bring them into our specialty, bring them into our field. I think we got to be more active about it. Screening. We need to. We know where all the disease is. We know where the amputations are happening, but we're having a hard time figuring out how to screen patients. And you'll see slides like this from other people, and you look at all the diseases here. Okay, breast cancer, they screen. Colon cancer, we screen. Lung cancer, they screen. CAD, they're starting to screen. They have the CT scan, they look for these scores, they have all these things. PAD, we're not screening. Why not? We're right up here at the top 5, but we're not screening. What are we doing? We got to be more active. This is the bill that tried to come forward to try to say that we need to screen, and it's been circling and circling, revision for probably the last 7 years. And it's never made it to a vote in Congress because I think right now it's in the House of Ways and Means and waiting to move forward. Why can't we do it? I mean, we know the patients, we see the amputations, we see the deaths. It's a global thing. Why can't we do it? Well, we can't. We just can't seem to get any energy to do it. I spoke in Washington the other year, I think it was last year, and I had the opportunity to meet the guy in the bright red. I said, who's the dude in the bright red suit? And and it was actually Congressman Donald Payne. He wrote the bill. And he talked about what he suffers with. He's on dialysis. He was really low energy. He just finished. He said he's been in walking boots, diabetic feet ulcers. His eyes were suffering, and he didn't know how much more he'd be able to go. But he's been fighting for this bill and hoping to see that he was able to get it through. And since then, he just recently passed away. And so what's going to happen now? Who's going to take up the charge? I don't know. And we have to see, because we have to do something for this, because it's for us to just sit back as surgeons. We're not recruiting. We're not bringing in more people. We're not finding the disease. We're not screening. It's almost like I think we're worse than internists right now in terms of how we're moving forward with this disease. We're supposed to be the action group. And lastly, what about advertising and awareness? So this was a study where they looked at PAD awareness, and they looked in the public, and they basically screened different people, and they said they have a total lack of understanding in terms of the disease. Only where they may know something about it is if they have another family member that knows. And they know it's associated with diabetes, but they don't understand that that could lead to an amputation. They do understand that they have to change their lifestyle, but not enough to say I could lose my leg. And so the public isn't aware. And then they screened non-specialty healthcare providers. And they said they didn't know. They said that their screening method was through an history and physical. If they asked people some questions and they said, okay, well, sounds like you could be at high risk, so I'll go ahead and do something at least. And the medical students didn't understand it. Only 21% knew about the screening method of checking an ankle brachial index. So we're behind there. And if you look at some of the TV ads, you can see all the different ads for food, Chipotle, Domino's, all these other ads. And then I said, well, somehow we have to at least get advertising out. I mean, the best trial, I think, should be a TED talk about how critical it is, how patients are they're dying, then you need to stop this disease. And if you look here under this website that pretty much ranks all the commercials that we see, I said, well, let me see what we have here in healthcare. And in the healthcare module, It's just some medications, AFib medications and estro, these different, nothing for PAD. Nothing for PAD. We're not there. And so I think we have to do better at getting in this space if we're going to really make a difference. And lastly, I think we have to be willing to change. You know, don't discount the trial just because you don't want to change. Don't discount things because you're fixed in the way that you do things, fixed in the way that your whole practice runs. It's probably very successful. Understand you may need to work with other people. You may need to collaborate with other specialists. And you may have to assist in preventive care. Maybe you do need to start prescribing, you know, more medications for statins and so forth in your practice. Well, I don't do that. Give it to the primary. Well, maybe we should, to be able to get patients on these medications that we need to combat the disease. I think we have to be careful because there is some handwriting, I think, that's happening on the wall for us. And hopefully we won't be shocked like Belshazzar and have our kingdom taken away from us. So I think the time is now. And I think really we have to move because time is running out. Thank you.
Vince, that was